All right, thank you for joining us for today's webinar, How to Address MOUD Stigma and Save Lives. My name is Marla Kaufman, and I'm the Senior Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar in a few ways. If you have questions for our presenters or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenters, Jess Williams and Cory Meutz. Cory, am I saying that correctly?
Yes.
Okay. We'll take questions and comments throughout the webinar. Feel free to submit your questions through the chat box at any time. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please take note that it will take up to 48 hours for your CEUs and certificate to be available in your MyIRETA profile because we have to cross-check your attendance with WebEx following the webinar. After the webinar, you will receive a follow-up email. This email will include a link to an evaluation form for the webinar, as well as more information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenters. Jess Williams, LCSW, MPH, has been working in the area of substance use, addiction, and recovery for over 15 years. She's worked as a researcher, a community organizer, and a therapist. Two of her core values are harm reduction and hope. Cory Meutz, BSCRS CPS, has been working as a peer in an outpatient drug and alcohol clinic for 3 years. He holds dual certifications as a certified recovery specialist and certified peer specialist, as well as a bachelor's degree from Robert Morris University in business management. He lives in West Mifflin with his wife and 3 cats, and his faith is a cornerstone of his life, marriage, and recovery. Cory is passionate about open, unique, and personalized recovery paths. He uses his own lived experience to relate to and inspire hope in others. Okay, Jess and Cory, I am going to close the survey. And pass it over to you both.
Awesome. Thank you so much, Marla. Let's see. I'm going to have, so my name is Jess Williams, as Marla so kindly introduced me. I'm very happy to be here. And in terms of questions and feedback, I'm going to be trying to monitor the chat and respond to things kind of in real time. We'll also try to create a few spaces for specific feedback, but if something occurs to you, please don't hold back, share it in the moment, and we may respond to it in the moment. And so Cory's going to be doing the slides so I can see the chat better. And so would you switch to the next slide, Cory? You all heard this. This is who we are. The only thing I wanted to share about myself is that I am a person in recovery. So I've got a lot of personal experience with addiction and recovery. However, I do not have personal experience with medications for opioid use disorder. And I'll ask you, Cory, if there's anything you want to add to your official bio.
Yeah, that's where I come in, is that MOUD was a huge part and still is a huge part of my recovery. I'll share my story in a little bit, but that MOUD was really like one of the final missing pieces to my recovery that really helped it click. So I'm very, passionate about just MOUD and its use and whatnot. I'm just glad to be able to share my own personal experience with others, and both personally and professionally.
Awesome. Yeah, thanks, Cory. And so if you have a free hand, and I will share that Cory and I both work in a busy outpatient treatment clinic. And so we know that like right now you might be eating lunch and doing your notes and like faxing something. So if you can't give us your full attention, that's fine. We'll take what we can get. If you have free hands, we'd love to know who you are. what brings you here, any connection you have to MOUD, where you are geographically. We're both in Pittsburgh. And so if you're willing to share anything about yourself in the chat, it would be great to hear from you. All right, next slide.
Jess, I wanted to let you know I do have the ability to unmute folks. So would you want to make it a little bit more interactive and have people speak? We could have people raise hands and ask questions that way, or we can just keep it to the chat if that's easier for you both.
Yeah, so I love the idea of people being able to contribute. However, in my experience, sometimes if people are unmuted, the audio can be like it can be distracting. So maybe we'll create a couple opportunities when people can unmute, but generally we don't want everybody unmuted because that seems like chaos. Does that
Sounds great. Yeah.
All right, cool. So community-based recovery services in West Michigan as a case manager, an administrative social worker in Chicago, admissions clinician here in Pittsburgh, what? Everett, Washington, an opioid outreach specialist, an LMSW in Oklahoma, a person in recovery. Awesome to hear someone as MOUD as part of your story. Cool. This is so neat. Awesome.
Yeah, people from all over. It's awesome.
Yeah, how fun. Um, cool. Keep that, please keep sharing who you are and feel free to interact with each other too. Um, we're going to take a minute to thank the Stoughton Farm Foundation. They have given us a capacity building grant, and that is something that we're using to kind of like beef up this project, which is still pretty small scale. But that's what we've been doing starting this past summer and moving into summer 2026. And we are so appreciative of their support. All right, next slide. So this is what I said earlier. We are going to try to create a few silent places where folks are specifically encouraged to share. The idea is that like we break for stories. Stories are like a huge part of this project. And so if you say you have a story to share, we're interested to hear it. You can use the chat, you can raise your hand. But yeah, as you'll see, this project is something that we're building while we're flying it. And that means that you have a lot of value to us and contributing what you're seeing, what you're concerned about, what you've seen working, things like that. So even though I know that this is not the most interactive format, to the extent you can and want to interact, we would love that. And now, because stories are so important, we're going to start with Cory's story, and we'll move into a little bit more about the project, the origins of the project. We'll take a step back and think about why this project in our mind is important because of pervasive and sometimes invisible MOUD stigma and discrimination. And then we'll kind of like come back to the present moment in the near future and talk about this project. If we have time, and I'm not sure that we will, there's another story that we'll be able to share by a really powerful advocate here in Pittsburgh named Cambria King. If we don't have time, we'll send you all the link because you can hear it anytime you want. It's on the internet. All right. Would you want to kick things off for us, Cory, with your own story?
Yeah, absolutely. So, like already established, my name's Cory. I'm a person who is in recovery, works in recovery. But obviously I didn't, with the role of a peer or certified recovery specialist, you don't just get the job, you have to have that lived experience. And my story, I mean, it really starts when I was like it started when I was like a child, really, like the lead up. But what when I first got exposed to drugs and alcohol was in high school, starting out with, experimenting with weed, alcohol, so on and so forth. But whenever I got exposed and tried opiates for the first time, that was kind of like I call it my first love, like especially Oxycontin. That was when it really like went from just experimenting and whatnot to like, oh, this is a problem. Um, so I really like I managed to mostly stay functional throughout my entire almost decade in active addiction, but I was trying to balance both being in college and being addicted to OxyContin, and those two don't really fly. And that ended up with me getting like a zero point 0.0 GPA, losing all of my grants and stuff. And I wish I could say that, and this is a kind of a recurring theme, but I wish I could say that through my own volition, stopped. But really, what happened was my dealer ripped me off, and he was the only person I knew to get it. So I just went through withdrawal, even though I didn't really know exactly why I was going through. Like at the time, it was just kind of foreign to me. I wasn't really aware of it, but I just went through it and managed to turn things around, graduated college, got a job. But it was when I started working full time that I just felt an emptiness and a sadness that I started filling again with drugs and alcohol. First being heroin, but then like the last time my dealer stopped answering my phone, so I stopped using that. And I should say I always had a really big fear of getting caught, mostly because I was always a very anxious child, a very anxious teenager, a very anxious adult, but especially so with getting in trouble for drugs, because the first time I ever smoked weed, I got arrested, which in a funny, ironic way, probably saved my life in a way, because that made me terrified of going out onto the street and finding drugs. So, um, yeah, without that, who knows? I might not be here today. But afterwards, a friend introduced me to Kratom, and that for me was like perfect. 'Cause it was I could buy it with my credit card, I could just have it mailed to my house. It was like perfect. So that essentially just became my life. Like I would wake up in the morning, I would do just enough to either get a little buzz or not get sick. I'd go to work, I'd come home, I'd get high, and that was my life for the better part, like about 5 or 6 years. And again, I wish I could say that like it was again through my own decision or volition that I wanted to stop, but I thought kratom was going to get decriminalized, and I didn't want to get caught with my pants down. So I was like, okay, I need to get help. So I went to a outpatient Suboxone clinic. Didn't actually ever think that I could get on Suboxone. That was never an option for me at first, but I got my comfort meds, I detoxed, and then since I never had a problem with alcohol, I was just like, whatever, I'll just stop doing opiates, but anything else I can still do. Well, turns out pretty much any mood altering substance, whether it was alcohol, whether it was medical marijuana, I would get addicted to it, I would abuse it, and that was kind of that. So over the next few years, it was sort of a back and forth. Sometimes I would be drinking, alcohol would be my main substance. But I would usually always go back to kratom. And the sort of the reoccurring pattern was every time I would want to get sober, I would sort of add something else to my recovery. Or at first it was therapy, then it was seeing a psychiatrist and getting on psych medications. Then it was IOP was one thing, but then finally after COVID started, that was like that first weekend, I was just like, there was that, a few other things in my life. I was like, I can't cope with this. Like the world's falling apart. I still at that time sadly didn't have the like coping skills to really stand on in my recovery. So I did return to use again, but after a couple weeks, I was like, I had just been through it so many times before. I was like, okay, what am I doing? I gotta stop this. So I called the same drug and alcohol program again, and only this time the woman at the front desk, who I'd become very familiar with by this point, suggested that I try Suboxone. And I didn't even know that was, again, I didn't even know that was an option for me. But she was like, yeah, somebody else at the clinic is on it, and it, you know, really works well for them. So I was like, okay, let's try it. So I did that. And in combination with going to IOP at Jade Wellness, like those two things, that is like what truly like saved my life. Like, and it took a long time for me to get like the Suboxone I was relatively open to, but everything else there was also a stubbornness, like because I was just so ashamed of, you know, of who I was, that I was an addict, that I told very few people. That was not something I was openly talking about. And I just, between the stability that the Suboxone gave and the coping skills and everything that I learned in IOP, that was what really like unlocked it for me and really helped me succeed. And even through going to IOP, I realized how I like the idea of like mind, body, spirit, and how I virtually had no spirit at all. And I sort of went searching for that, and again, somewhat stubbornly kind of went the opposite direction of Christianity. But eventually, after meeting my now wife, she kind of introduced me to the faith, and then that became another big cornerstone to my continued recovery. Because while I'm blessed to have over 5.5 years sober now, like I still know that it is something that, you know, is not a guarantee. So it's something that I have to continually work on. And thankfully, all those things that I picked up through each return to use, I still have, and slowly built up into a more well-rounded recovery that I am proud to say that I have today. And I guess just one last thing. It was when I was nearing the end of my IOP at Jade Wellness, I started helping out other people in my group, like just helping them with like their resume, taking someone to court. And they always had these flyers on the wall. And I had a CRS myself, but I'd never even heard of it until I went there. And I think I just had the idea of like, I'm kind of already doing this like just on my own. I like doing this. I enjoy helping people. I was kind of miserable at my current job. So I was like, why not do this? So I got into the CRS class, eventually found a job at, again, said outpatient drug and alcohol clinic that I currently work at alongside Jess. And that has just been a tremendous blessing in my life, because I'm primarily helping other people, of course, but then it helps my recovery as well. And things that I, you know, work on with other people, like I learn, or it's just a good way to remember sometimes, because sometimes we forget in long-term recovery what it's like at the beginning, what it's like when you're going through yet another lapse. And it's just been a blessing to be able to help others, but also get a benefit to my own recovery as well. So that's pretty much it. That's my story. So thank you all for listening, and thank you, Jess, for giving me the opportunity, and Iretta for giving me the opportunity to share.
Thank you so much, Cory.
Mhm.
One question that I have for you that I don't know if I've ever asked you before, is about like stigma from the outside or internal like self-stigma that you experienced.
Mhm.
I'm curious how that fits into your story.
Um, it was a lot of self stigma. Like I, so it wasn't, I wasn't as much ashamed or afraid to tell people that I was on MOUD for as much as I was like to just initially anyway share that I am, um, a person in recovery. There's definitely been times that I felt like based on the location I was in, I felt very much a bit ashamed to be on medication, but that was, that was something that was I never personally like took to heart, but sadly I do work with a lot of people that is a very very difficult thing, like people that they are maybe in like a 12-step program that just people in their home group or whatever share how oh, people that are on Suboxone are still an addict and this and that. So it's something that now I see more in other people's recovery than I ever did in myself, in my own recovery.
Uh, Cool. Thank you so much.
Mhm.
I do see there's a lot of folks who are thanking you in the chat.
My,
And Kathy's noting that she works in small town Minnesota and she sees a lot of stigma.
mm,
And that as a LADC, she's not thought of as providing treatment services to patients, which I'm not sure if I totally understand that, Kathy. Um, because you're a associate. I don't know what LADC is. I'm sorry. Um, yeah, but
yeah.
please, we'll keep an eye on the chat too.
Yeah, and
Yeah.
I would just say one, probably like again, the self stigmatizing thing for me was the fact that like I didn't think, because I've read that some people do use kratom as a means of harm reduction to come off of heroin or fentanyl or whatnot. I thought like, oh, I can't be on Suboxone or any type of MOUD. Like there was sort of that sort of self
Mhm.
stigmatizing going on. So um, I would say if there's one thing like to maybe take from my story is that if anybody does come across somebody that is really struggling with kratom addiction, that it is a very um, viable option to
Mhm.
get off, because I just that was just it. That was like that final missing piece for me. So I just, yeah, like I said, if that was one thing to take away from my story, I would hope that would be it.
Awesome. Yeah, and that's an interesting one is like, okay, yeah, Kathy's saying licensed alcohol and drug counselor. I see. Yeah. She says that most of her patients don't view their program as treatment, just methadone, just buprenorphine, not
Mhm.
alcohol. Yeah. Yeah, I get that. Um, well, cool. Thank you so much, Corey. And
Of course.
I will say that, like, probably you can already tell that Corey has knowledge I don't have in a lot of areas. And so, even though I sort of put together the slides for this talk, um, Corey's going to contribute in areas that I don't do as well in. So jump in, okay, Corey, as you want. Um, Yes, and a lot of people are saying that that issue of kratom is something they're seeing as well, or at least Sarah's saying that people don't know that Suboxone is a viable treatment. Um, well, let's go to the next slide. Yeah. All right. This is a question from Jim Winkle saying, would you say, and I'm guessing this is maybe for both of us, that for most people with OUD, they have to forge a pathway over time, beginning with reducing harm and improving their quality of life to eventually accept MOUD, or
Mhm.
are they ready for MOUD immediately?
Hmm.
So I'll start by responding to that and saying that I think people think of MOUD as a tool to do different things, and I am good with that.
Mhm.
Like I see people showing up very motivated to our clinic or to our needle exchange, which will provide Suboxone scripts. And their goal is not like the word recovery doesn't apply to what their their goals are.
Mhm.
But like they're sick, you know. Uh, and so I think sometimes that has led people to be dismissive of the powerful role of MOUD in their recovery because they're like, I wasn't even trying to get well, or I wasn't even trying to recover. I was trying to do something else. And so they don't, there's at least I see that as like, it didn't help me. My real recovery started later. And I think, oh, maybe your real recovery started then
Mhm.
when you reached out for help. What do you think, Corey?
Yeah, so I'm just trying to think, at least like for me, I actually don't know if it's something that has to, I'm sure for some people it is something that has to be like built up to, but I don't know, I think I would struggle to say that would be the case for the majority of people. And that's mostly because being sick from opiates, it sucks. Like the first time I quit using kratom and I just had comfort meds. I mean, I think I was sick for like the better half of 2 weeks. And like I know that's not that much time in the long run, but like if I would have been more open or just known that Suboxone was an option then, I think I would have taken it, not just for the immediate effects, but for the long term like stability as well, which is what's nice, I think, about MOUD is it
Mhm.
helps in that short term withdrawal phase, but also helps stay uh, sober as well, or stay uh, whatever the person's recovery goal may be.
Well, I'm gonna talk a little bit about this project. And as I said in the beginning, we are sort of building this while flying it, and it's pretty small scale. Um, and the hope is to continue to grow it. And anybody that contributes to this conversation today is helping us to figure out how to grow it. So thank you for that. Um, uh, so next slide, Corey. This is a picture of, or this is a bunch of pictures of the Pittsburgh Recovery Walk. Um, and in 2016, I was working at IRETA, and I had the like privilege to get started with a work group. And some of those folks are on this webinar right now. To put together this event, which grew over time. And the idea was let's all publicly celebrate and learn about recovery from addiction, which is, thank you, Caitlin, which is uh, at the time I thought so important, and I still think is so important. And I hope that these pictures will sort of convey what a meaningful event it is.
Yeah, I just have to say, like the first time I went and seeing like just just it's a huge crowd and being like whether it was just like wow, like everybody is here that is either like me or is supportive of me in some way, and as someone who is so shamed and like so like hidden in my recovery, like to have an event that is so open, it was just such a beautiful thing. So
Well, next slide, Corey.
mhm.
Beautiful. So
Mhm.
so I did then in 2016 think it was beautiful, and I still think it's beautiful. And as you can see, there's so many different kinds of people there. Next slide. And one of the big goals of the Pittsburgh Recovery Walk is to celebrate all roads to all recovery. And that means that we're trying to kind of like break out of stereotypes or narrow views of recovery and talk very broadly about this phenomenon that happens every day, which is people struggle with substance use disorder and then they get better. And so here are people doing that together. Next slide, Cory. However, there was something that was niggling me. One thing that I observed happily is that over time we had more and more people that wanted to speak publicly about their recovery story. And I knew that it wasn't just the Pittsburgh Recovery Walk that was creating that phenomenon, that there was actually like a much larger movement, maybe could be broadly called the recovery movement, that was encouraging people to sort of come out of the closet and talk about their recovery. And it was very cool for us to be part of that and to see that that really was happening. We could see that sort of like bubbling up of enthusiasm and openness. However, one thing that I did not see was more people wanting to talk about MOUD. And time passed, and uh, still this was a problem. It was like, do you know anybody? Do you know anybody who knows anybody? We want to make sure to represent this, and it was hard. And during that same time period, people were really suffering opioid-related harms, particularly in Western Pennsylvania. We've, for many decades, been a region where there's a lot of opioid and heroin use. And as the opioid epidemic unfolded, that was so very true here. And we were watching it in our backyard. And so I thought to myself, I don't think that this recovery movement, hashtag recover out loud, I don't think that there is necessarily an intention to exclude these MOUD stories, but I think the fact that they're absent is it's contributing to a certain kind of stigma. It's telling us that there's some recovery that is more legitimate than others. And when it comes to opioid use disorder, I also knew that medication is like by far the most effective way to promote recovery and save lives. Did you want to say something, Cory, or no? Maybe I'm.
No. I'm just agreeing.
Cool. Yeah. Just and so that started to concern me because I thought, is the Pittsburgh Recovery Walk inadvertently perpetuating some kind of stigma here by not sharing enough of those stories? And we wanted to do this good thing. And are there ways in which we're also creating harm? And so I thought about that, and the question of what can we do more or differently was something that kind of met with a funding opportunity through Shatterproof. And so I was like, let's do this little project. I have an idea. All right, next slide. So this is me having an idea. And I thought to myself, we just need more people to come out of the closet, right? We've got people coming out all over the place. We just need to create a storytelling program. We need more stories, right? I love a story. For me, it was like so compelling just to start this out with Cory's story. And we just need more of these stories. And so I put together a very small grant. I think it was, I don't know, $7,000 or $8,000, not much, to create this tiny program. And I wanted potential storytellers to have mentorship and support to sort of come out. And that could be on social media, that could be in the more traditional media, or it could just be with like family and loved ones, maybe in a 12-step environment. And so we kicked off that storytelling project. And next slide. And so these are some of the people that joined that project starting in 2020. 2022. Some of these faces might be familiar to you. And they were all interested in this work as well. And most people involved were connected in multiple ways to addiction and recovery, and specifically opioid addiction and medication for opioid use disorder. However, through this group, and there's more people that aren't pictured here, including me, I really got a sense of how wrong I was about this project, and that storytelling requires a lot more scaffolding and support than I had sort of imagined. And so this group I credit with like setting me straight, basically, and giving me a lot more respect for the work that needs to be done to alleviate MOUD stigma. And so it was pointed out that the recovery movement, which had a lot of folks who participated in 12-step, that was a space that coming out urge, desire, was supported by a lot of 12-step rooms, a safe space where people could share their stories, and that those safe spaces had been developed, cultivated, made safe over many, many decades. And so asking someone to come out and talk more openly about their MOUD history and experience was like a pretty risky thing to do, and there really weren't enough safe spaces where you could go and sort of lick your wounds if it didn't go well, or practice your story, or feel validated even if the world did not approve of or support you. And so the orientation really changed, I think, in the right direction, which was recognizing we need to start thinking a lot more about safe, or you might say safer spaces. Maybe there's no such thing as a perfectly safe space, but we needed more safer spaces, because there wasn't that support, that infrastructure. And so together we talked about 4 tenets, and these are the tenets that we've carried forward over the past 3 or 4 years. Creating safe spaces, tackling myths, promoting justice, and coming out. And you'll notice that coming out is last there. And so we started to think about where the project would go from there, and we scrapped sort of the original concept. And the next slide, Cory, will maybe show some of the place that we landed. So what we decided to do was to create a zine. And one of the reasons that we decided to create a zine was that we recognized that there was a lot of institutional mistrust in 2022, just like there is in 2025. There's not necessarily trust in healthcare providers or in government. And there had been considerable efforts from scientists, healthcare providers, and government entities to try to improve uptake, utilization of MOUD. And so we thought we need a different tone here. This cannot look like a glossy brochure. This needs to feel more peer-to-peer, more grassroots, and more personal. And so that's why we ended up with a zine, which is, for those of you who aren't familiar with that term, sort of like a DIY magazine. And so let's see, I'm thinking, Cory, would you stop sharing and I will actually show folks the zine itself. There we go. And oh no, I'm gonna accidentally share. Okay, this is better. So here we go. Here's the zine we produced in 2023. It's a guide to surviving and thriving in the Pittsburgh area. And the illustrations were very beautifully done by Lizzie Anderson, who is an artist and social worker here in Pittsburgh. These are the people who contributed in this first year of the project. And you'll see we talk about why we use the term MOUD, who created this guide, and what's the history here. And then we get into stories. We organize it around those same 4 tenets. So creating safe spaces, busting myths, promoting justice, and coming out. And you'll notice that we share some resources and ideas, and that we made it sort of like a little interactive here. Thanks, Marla. And so we encouraged people to kind of take this zine and make it theirs, because it's not up to us necessarily to decide whether something is a safe space. Yes, Nora, I will share where the zine is. Actually, I think Marla might already have. And it is Pittsburgh regionally specific, which we'll get to. We have hopes to create something that is not so regionally specific as well. And so let's see, I'm going to stop sharing. And so that zine, actually, maybe would you share now, Cory?
Yep.
Thank you. That zine we created, we printed a bunch of copies of, and we also keep hearing about people printing it themselves. And so like that was super exciting. This is what we really wanted. We wanted to kind of lose control of this project and have people take it and make it their own. And so there is a woman that lost her son to an overdose who somehow heard about this zine, and she prints it and distributes it at a farmer's market in Pittsburgh. She has a little stand there. That's what we wanted. There's a psychiatrist who I just adore who works at a local buprenorphine clinic here, who every client he has, every patient he has, he says to them, is there anybody in your life who doesn't understand that Suboxone is a healthy thing? And if they say yes, he hands them a zine. And so, like, that's exciting to us. And I think that gave us encouragement, like, okay, well, we're on the right track, or a right track. And so, over the year or two that we worked on that project, there was a couple articles in local media about us. We presented a local conference, and we got good feedback. We did a little bit of evaluation, and this was actually incidentally before Cory got involved, before I like twisted his arm to that showed that the people who were in the work group found it to be rewarding and energizing. They felt more motivated to address MOUD stigma in their personal and professional lives as a result of it. So next slide. So that funding ran out rather quickly, and starting in 2024, we were kind of left thinking like, well, what are we going to do next, and how are we going to do it? And I'm taking a break. I'm taking a moment here to reflect on the phenomenon of MOUD stigma, because it is what keeps us going forward, right? It is the reason that we're here now, we're doing this work now, and that we hope to continue.
Yeah. I think ideally, maybe one day we don't have to do the work anymore. Like it'll just be known. Like it'll just be out there. Like kind of putting ourselves out of the job, in a sense.
I couldn't agree more. Yeah. Yeah. So let's see. Next slide, Cory. So this is I find it hard to share this information in 2025. Because these statistics are so tragic. And I think there is a bit of numbness that sets in. And I think the only way to make any sense of them is really through stories, which we don't have time enough today to do. But At this point, 25 years into an opioid epidemic, we've lost nearly 1 million people to overdose. And I found this story very moving. It was published not so long ago, and it was not about someone who's died of an overdose, but someone who has survived and requires round-the-clock care from his mother, who's very devoted to him. And I think we're learning more and more about the impairment, the harm of non-fatal overdose as well. There was a study done and published in 2020 by Dr. Eric Halsey, the director of IRETA, just showing that locally, in a 14-year period, there were 1,000 people in our county here who had lost a parent to overdose. And we see this all the time, and I know you see this too, is that as the epidemic has evolved, we've had to watch new and often worse harms occur. And I can't, that has to be the backdrop of this conversation. And it's really, it's almost impossible to kind of wrap our mind around the scale of it. And so all I can really think to do at this point is to just offer a moment of silence for all of us, to think about this harm that continues. Thank you. Would you go to the next slide, Cory?
Yeah.
I'm not going to show you a bibliography about the effectiveness of medication for opioid use disorder. There's a lot of research that demonstrates that. And if you or anybody is unconvinced, you can see what NIDA has to say. You can pretty much look to any authoritative body on addiction and its treatment, and the results pretty unequivocal. And I think that is a little bit what makes it so painful that so many people continue to die, because we have a pretty good solution to at least the problem of death. Yes, so Marla, Dr. Johnson, I did not, this right now does not have references in it, which is me not finishing the slides last night. But when I send out the slides later today, or when I send them to Marla at IRETA and she'll send them out, it will have references. However, it's possible, because Dr. Halsey is on this webinar, that he would be able to provide a quicker answer to your question. There we go. Yeah. So next slide. And so this conversation just keeps happening, and it's maddening at this point, right? MOUD, particularly methadone and buprenorphine, are the gold standard for treating opioid use disorder, and we just see not enough utilization of them. And so these are also slides that need references included, which I will share later. But 2022 study showed that only 1 in 4 people who are receiving, or who identified a need for opioid use disorder treatment, had used MOUD within the past year. And there's been a lot of focus on access, MOUD access, and that, of course, is important. And so there's not as much access as there ought to be, right? Even in substance use disorder treatment, even people specializing in substance use disorder treatment often don't offer these medications. There's all sorts of issues with the criminal justice system. The mental health system often fails to even address addiction at all, including the provision of evidence-based treatment for it. And then, of course, healthcare continues to fail these patients. PCPs can provide buprenorphine and Vivitrol, and they don't do it nearly enough. And so what we've seen is some progress on the access front, and so that's a very good thing. The Department of Justice sued the Allegheny County Jail here locally, and they are now required to initiate buprenorphine rather than just to continue existing prescriptions. There's also been an effort to ensure that all people in jail can access methadone, whereas previously it had only been pregnant people. A few years ago, there was a big and successful push to get rid of the training requirements for physicians to prescribe buprenorphine. And it was argued that it creates a barrier to prescriptions prescribing and makes it seem like it's a weird and different thing to do, not part of the normal treatment. There's been an effort here in Pennsylvania to license recovery houses and only license those who allow the use of MOUD. And those are all very good things. However, there's this other issue, and you've probably seen it too. Next slide, Cory.
Yeah, one other thing, and I think this is what you're about to get into, is that like the people that have access to MOUD, but for various reasons choose not to.
Right. Yeah. So that's where we are, right? That's the problem, right? And so there has been more of an interest in this issue of MOUD stigma. And so could you click that
Yeah.
slide? Yeah, right. So we're seeing more research into this, right? Stigma among treatment providers, those who might benefit, who have OUD. Can you click it again, Cory? This is my this is my fancy slide. And so these articles have been published more recently. And then one more, right? So there's a recognition that stigma is playing a role. And that is like very much in line with what I've seen. I know you, Cory. Next slide. Right? So we see this all the time. Even when these medications are made accessible to folks, patients themselves often express skepticism and aversion, and messaging from peer-based support and the larger social environment often conflicts with that of evidence-based treatment providers. And so that means that a person with OUD is forced too often to choose between a medication that has been shown to effectively treat OUD and social support, which also has been shown to effectively support recovery from OUD. And so this is actually a place that I thought we could create a little bit of silence. Would you mind stopping sharing, Cory? Yeah, do you where do you see this, right? Like we're not the only ones. I think you're probably seeing this too. We're just gonna maybe create that time and space. How are you seeing this manifest?
And I would also maybe ask to like how do you address it with people that have the skepticism and aversion? So I can say one thing that recently we've seen more of a push in Allegheny County is both the treatment of physical and mental health at the same time. And then I kind of use that to open up a dialogue of like to try to compare these mental health conditions to physical health conditions. Like, if you break your arm, like, could it heal on its own? Like, yeah, sure. But if you don't treat it, the chances of it healing correctly or healing at all, like, decrease or
Cool.
something, or like maybe even relating it to like other physical health conditions that require daily or monthly
Treatment.
medications as well.
Cool. Yeah. Thoughts from y'all? We'll create a little more silence for you. Can be uncomfortable. Mm-hmm. 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 Yeah. So Brenda says, I hear from my peeps this issue of swapping one drug for another. Yes.
Yeah,
Um,
that is something that I think is like on one part good to like validate the concern, but also like I think that's where at least I try to use those other analogies to try to combat that a little bit, because I personally understand too is like it can. There was a time where I was trying to get off Suboxone, and it's hard. It's not easy. Like, and that's where I actually utilized the Sublocade injection to help like get off. But then, since gotten back on it as well, which is another thing I will just share in my story, because I'm not a doctor. I don't give medical advice. I just share my own, experience and suggest people talk to their, providers. But
mm-hmm. Mm-hmm. Yeah, and I think, yes, um, yeah, people are talking about this idea of clean, right?
mhm.
Clean versus dirty.
Yeah, and I know Sylvia mentions like the and like where does like the dose limit end with methadone or Suboxone? Like that can
Mm-hmm.
be um, just difficult.
Mm-hmm. Yeah. Um, yeah, here we go. Strong disdain. Yeah. Yeah. Those people, judgment from people in recovery. Um, yes. People who are going to have surgery, they're being rushed to get off their
Yeah,
substance meds. Yeah. And that's
and
not, yeah.
no, and I'm actually thank you for sharing that, Tiffany, because that's actually I had surgery when I was on Suboxone, and that's not something that I guess that's a part of my story that I never really thought about as like important, but it is because I mean I was able to get it. They just told me to take it as prescribed up until the day of the surgery, and then I think they had me take it after the surgery. It's been a couple years, so I don't quite remember, but uh,
Mm-hmm.
yeah,
Yeah. Uh, this time it's hard to ignore the judgment from those in recovery, from the type of medication, the number of times someone's been in treatment, the reason they started to use it. If you're a mother, a father, right? Yeah. There's so, there are so some treatment centers that won't accept you at all. That does not help. Absolutely, right?
mm-hmm.
Mm. Yeah. So this is really helpful to hear as you think of other things in this domain. I think it's really interesting to once we bring this lens, like even Cory is like thinking like our own experience, we start to see that there actually are barriers or stigma that we didn't even detect necessarily. So please do share as we continue. Um, I'm gonna maybe go back to the wherever we were. Um, yeah, and so the next, yeah, so here we go. So the trouble, of course, and is that stigma and discrimination reinforce themselves, and so there's actually illegal discrimination taking place all the time, but those people who are affected are unlikely to advocate for themselves, right? If you are a stigmatized, ostracized group, if you internalize that stigma, instead of saying, hey, this isn't right, you don't have a right to do that. I'm a protected class under the ADA. Instead, you can be bullied. And so we see this from employers ordering people off their meds or ordering them to very arbitrary dose levels. Professional monitoring programs, that is a passion of one of the people in our group, including physicians themselves. The same people who are supposed to be prescribing these medication, if they are in a monitoring program for their own recovery, in many cases, they're not permitted to use MOUD. We've talked about criminal justice, child welfare systems, and as you say here, treatment programs and recovery housing. And so how can they get away with this? Part of it is stigma, right? So next slide, I will just remind all of you that people with opioid use disorder are protected under the ADA. On their website, there's a very clear description of what are some examples of illegal discrimination. And there is a way at which you can file a grievance. Anybody can. And that doesn't happen enough. So stigma is distinct from discrimination, and yet it really fuels discrimination. And so, all right, next slide. So that's sort of the context that we are working in. And so, yes, exactly, Bonnie. That is part of what what we are hoping to do more of, is make people aware of the protections that they're entitled to. So as I mentioned, in summer of 2025, we got a grant to work on this project and to try to build capacity in it from Stoughton Farm. And so that's what we're doing now. And we are in the middle of that. We're not at the end of it. And so what you'll be hearing is some of our in the middle of it thoughts and ideas. So next slide. What we're doing now is we're continuing to come together as a work group. We're developing our online presence, so we're getting a much less janky website. We're getting like a real logo, and we will be an online, a much more substantial and professional looking online presence. We've also been hosting an online MARA meeting. MARA is Medication Assisted Recovery Anonymous. Cory's a facilitator for that, as am I sometimes. And I will come back to that, Cory. I want to actually, you and I haven't even gotten a chance to talk about this, but I do want to come back to that MARA thing. And we also have a plan to do an in-person storytelling session on a monthly basis starting in 2026. We want to reach out to other organizations, and we want to create some additional zines, which I'm so excited about. So next slide. That was what we wrote into our grant proposal. We also have been sort of evolving, as this project has since day one. As we come up with new ideas, we recognize new needs, and we just like slowly build an understanding of the landscape and what might be helpful or positive. Something that we recognized, we got a request for, and that I think we're noodling over, is creating an informal sponsorship directory. And so these are sort of like word of mouth people who participate in AA, NA, and other 12-step, who are willing to connect with a new person and help them sort of find their way in a 12-step environment. And so we have right now just like people we can text, and we might put together something a bit more extensive and encourage people to reach out to us if they're in the Pittsburgh area and they're looking for a sponsorship or even just sort of like an ambassador to 12-step. We're recognizing a need to be supportive or at least shine a light on local efforts. And right now we're seeing that there's been the sort of abrupt closure of a local methadone program. And we're participating in listening sessions and trying to connect with advocates around that. And then again, as you said, Bonnie, people need to be aware of their protections. And so we want to continue to illuminate the fact that you can file an ADA complaint and it can be anonymous. It doesn't have to have your name attached to it. But that we actually met with the lawyers who work for the DOJ who read those complaints, and they said they read every single one. And I think we also want to shine a light on the online Mara community, which I am just starting to understand is awesome. um, and yeah, that is really good news to me. That although I myself have not been somebody that's built this community, I have gotten a look inside and I can say that it's really terrific. And how can we show people this is a resource and those people rock. So next slide. Um, these are all ideas for our next series of zines. And these are experiences that we think would be interesting to highlight using stories. And I'm going to give you a minute to look at them. And if you like, you could use the chat to share anything that you think is a particularly good idea, or conversely, anything you think is like a particularly bad idea. At the bottom, you'll see injectables, which Cory mentioned as a way to come off of MOUD, or a way to kind of like feel differently about MOUD. And that's been interesting to kind of think about. There's also another connection to Cory's story is Kratom. What is Kratom? What is 7-OH? How could MOUD help? And we're aware that some of these medications may be banned, or some of those drugs may be banned, which now people have very ready access to. And would that, if that were to be the case, it would be quite important for people to understand that MOUD is an option, because who knows what would happen to somebody that was regularly using Kratom or 7-OH and lost access.
Yeah, that is, like we discussed at the last meeting we had, like a very popular chain of gas stations in the Pittsburgh, like a more corporate chain, now sells and advertises Kratom, and just trying to figure out, like, the people that are buying Kratom at these places, do they know what it is? Like, I can at least say I knew what it was. I maybe didn't know how sick I was going to get when I tried to stop, but I knew what it was. Like, and I've heard stories of people just thinking it's like an herbal supplement, or it's something that, that's like, that doesn't really come with any negative effects, but it, very, very much does. And if that rug were to be pulled, that, I could envision that being similar to the overuse of prescribing pain medication and then being cut off, and how that led people to heroin and fentanyl, and or buying pain pills from the street, and how that could have a similar effect.
Yeah, absolutely. It's like it's yeah, how could we be helpful and try to mitigate the worst consequences of that? Yeah. I'll give you, yeah, I don't know. Anybody have thoughts? Because you're hearing stories too in your work, and you have your own story. Maybe even just trying to be an ally, right? Or as some of you have described, encountering stigma and figuring out ways to work with it. Cory talking about this is medical condition. You could treat it medically, or you could treat it otherwise. Uh, yeah, I think like this is something. Yeah, yeah, absolutely. Thank you, Estefania. I hope I'm saying that properly. Yeah. Mm-hmm. Is it best for the patient to avoid mentioning or taking treatment meds? Okay, so let's see. I'm gonna, okay. So I'm seeing what you're saying here, Tiffany, is when dealing with physicians or people in the medical field, is it best for the patient to avoid mentioning taking meds, or should they not be concerned about medications not mixing? Yeah. So obviously Cory and I aren't doctors.
Mhm.
Let's just say that.
Mhm.
But did you want to say something to that, Cory?
I mean, I can't I can't think of any um I can't think of any personal experiences I've had where like a doctor has I've like talked about a medication, they've said no because or they've said that it has effects, but I can imagine I don't know, I'm just again thinking of it like it's probably always like you just want your medical providers to know like what you're on so they can ideally treat you in the best way. And I would think withholding that information while I can understand like the fear or the risk would be um, unadvantageous. But again,
Mm-hmm.
that's just my not a doctor opinion. Um,
Mm-hmm.
but definitely again validating that fear of like, do I tell like because it's not like again using like the physical health like a diabetic person I wouldn't imagine would be scared to tell their provider that they're on insulin every day like um but again not a doctor can't say with any type of real authority in that sense.
Um, yeah, I have to say, Brenda, I love the comparison with Wegovy too. I think these GLP-1s are like really great for like thinking about the value of medication in a disorder that has a behavioral element or sometimes has a behavior, like obesity and overweight. You could say that behavior is a major contributor, like diet and exercise are a minor contributor, but that medication can be helpful. And uh, and they're so widespread, and I'm really excited about being able to draw that conclusion or that connection. Um, Well, I think, yeah, as a person with lived experience, stories about people being on Suboxone long term, says Courtney. If I would have understood this is something that was okay, I would not have had the revolving door of being in various treatment centers. Yeah, oh my gosh, this is just really landing for me, what you're saying, Courtney. Um, if I would have understood this is something okay, I would have not have had the revolving door. Also, I'm being told that Suboxone is bad for my health constantly by others in recovery, but my alternative is much worse. Yes. Um,
Yeah, and I think it's fair to acknowledge like that I think there are some like again don't quote me on this but I believe there was I don't know if it was like a class action lawsuit or something like that about like Suboxone and people it damaging people's teeth. And
Mhm.
again, please don't quote me on that. I could be totally wrong, but um, I think it's fair to like maybe acknowledge some of those things, but also I think just the way you said, like the alternative is so much worse
Mhm.
that like I'll take that risk. I'll take that risk all day. Like, and
Mhm.
that's something for me personally isn't a real like a concern about any um type of long term. Like, you know, I still get the subligated injection monthly, um, and have been for years now at this point. Um,
Mhm. Mhm.
yeah,
Yeah, and so
good point.
that. Yeah.
There's
Mhm.
ways to yeah, the dry mouth. Oh yeah, the I utilize those like lozenges that help with dry mouth for that. So
Mhm.
all good points though that like even some of the potential like negatives, like if somebody says like, oh, it causes dry mouth, well there are, you know, or just asking like, did you know there's, you know, dry mouth lozenges or um, stuff like that. But yeah,
Mhm.
also very good point, Courtney, about my teeth that got damaged. Yeah, I say I'm very lucky that all my tooth damage was in the back, not the front. Um, so
Um, well, this is so really valuable to hear, and like it feels really good to be in a conversation with you all, and to feel a kind of sense of like kinship. This is work we all believe in, and we're trying to figure out together. Um, would you go to the
yeah,
next slide? Yeah. Um, so so this project right now is being evaluated. We don't have a ton of data, and we don't have much evidence at all that we're helping to reduce MLUD stigma. So that's our impression, but we cannot prove it with data. Because we have a capacity building grant, we're mostly looking at process outcomes. So are people coming to our meetings, to our storytelling sessions? Does the website get built? Does anybody come to it? Are we reaching out to organizations? Do we make zines? And at the end of this particular chapter of the project, we're going to repeat this survey to people who are in our work group, and again, measure their overall satisfaction, the value they perceive, their readiness, hopefully their increased readiness to share stories, motivation to fight MIUD stigma. Um, and and that is an area, if I was a researcher, and I'm not very good at that stuff. I don't think I have the attention span for it, but I think that is a point of interest for me. My perception is that the people in our group um, are mostly working on the front lines. I include myself, Cory, a lot of the other folks working with us. And I think that being part of the MOUD, the PGH MOUD project is combating burnout. I think it gives us a way to advocate beyond the work that we're kind of in the trenches doing every day, and gives us energy to do that work better. And I think that is exciting. Um, but that's not what we're measuring right now. Um, all right, and I think that maybe, let's see. Oh yeah, um, so I think the last slide here is again an opportunity. Yes. So Courtney, I will share where to find our online Mara meetings. And that is something that I do want to come back to. And this is maybe a lesson learned for others too. Um, so our online Mara meeting is listed on the Mara International website. Um, let's see. Maybe I thought that GIF was really cute, but I can't look at it. Maybe would you stop sharing it, the screen? Um, So our idea, we were like, oh, we need more support for those using MOUD in Pittsburgh. We should start a Mara meeting. And um, and so we decided to do it online because people are spread out geographically. We thought it'd be easier. We're not getting like a big turnout from Pittsburghers per se, at all. Primarily from people in different parts of the country. And that's why we want to do a face-to-face storytelling session, separate from the Mara meeting. However, I've seen this before where like recovery community organizations or just well-intentioned people like us are like, let's start a Mara meeting. And I think that it might be more beneficial. And if I could do this again, I would have maybe done it differently to really do some work trying to connect people to the existing Mara community. Because those guys are doing this work um, in a very organic and energetic way. Um, and so, uh, like, we're doing this for a year, maybe while we have grant funding. But for the people who are hosting Mara meetings, they're doing it just indefinitely because this is their passion and this is their experience. And coming up over Christmas, they're having what they call their Christmas marathon, which is like 48 hours or maybe 24 hours, but like they're just sitting there waiting for people who want to connect. And that's awesome. I'm not doing that, I don't think, at Christmas. And so being more of a facilitator, and recognizing that Mara itself has its own culture and history, and we can't just kind of like necessarily replicate it. Yeah, what do you think about that, Cory? That's been on my mind.
Yeah, no, I think that's a fair point. And like, while there is that storytelling element of that you get with Mora or any other type of meeting, I think having our own like the in-person sort of storytelling meetings probably more aligns with our organization and our mission more so than trying to piggyback off of another one.
Yeah. Yeah, but I mean the news is good when it comes to Mara. Like we've gotten to know some of the people that have been working on that for years, and they're cool. Um, all right, I think so that's all the slides we have. What questions do you have? I hope that we've kind of created it back and forth throughout, but we do have some time here at the end, so questions? Well, the state prison system see methadone. You know, I really don't like, I don't know. I don't think like Cory and I know the answer to that. But does somebody else here know?
Yeah, the only thing I can speak on is I believe Allegheny County Jail will like they had a relationship with a local methadone clinic, but I can't speak any more on it other than that. That was just something that I've heard of.
Hmm.
But maybe just to share that it's at least happening at a county level somewhere, and that maybe it is possible on a state level as well.
Um, yeah, this is such a thank you, Cory. Yeah, so I wish we knew, and it's possible that somebody on this knows. However, I don't. Kenzie asked a question that feels like maybe a little bit more aligned with what we know, which is what would be a few ideas to support someone using MOUD in recovery while their family members strongly stigmatize that choice. And I think one thing that we come back to is safer spaces, right? Like, can that person find a place that is supportive of their choice?
Mm,
Because advocacy requires, in our experience, advocacy requires the sense of being supported.
mm,
Um, and so if they can kind of like find a home, find a place where they're feeling the love, that might empower them over time, mindfully and strategically to either, communicate differently with their family members or just, do their thing without worrying about their family members. Yeah, what's your thought, Corey?
Um, I think the thing that like I go back to is like trying to mirror the analogy of like physical health to MOUD, or even mental health too, of um, like looking at it as a condition that, while yes, there are like MOUD is not the only way, but it is a way, and um, trying to just and not to like and using it to try to inform rather than convince, because sometimes like as try as we might, we just people are just going to be sort of set in their ways. And I know, and I think also acknowledging the struggle that that person would be in to like have a family like that isn't supportive of the medication that they are on, because that just in and of itself is difficult. But then also to, like Jess said, supplement it with like if they can't find that safe space, if their family is not one of those safe spaces, where else can they go to get that support that they need?
Hmm. Yeah, that's what Courtney's saying. Um, um, would be a good place to get support. And even like the zine can be something that's validating, supportive. So it doesn't always have to be a group of people, but just something that feels like, yeah, you see me.
Mm-hmm.
um, yeah. Marla, I see you here. I know that you're probably going to do a wrap up at the end. Do you need a minute or two to do that?
I am going to do just a few housekeeping items, but if there are any more questions that you want to answer, please feel free. But if not, I can just launch into it. So, thank you so much, Jess and Cory. This has really been fantastic. It's been great to learn more about this amazing project. Let me just pull up my little script here. So we would like to remind folks today that a PDF of today's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IREDA's website within the next week or two. I now want to remind you of our evaluation and CEU process. You will receive a follow-up email from us. It will include a link to the evaluation and step-by-step instructions on how to obtain your CEUs. We do want to note it will take up to 48 hours for your CEUs to become available in your My IREDA profile. If you have issues accessing your account or your CEUs after 48 hours, please feel free to email me at marla@ireda.org, and I'll be happy to help you access those. Again, we want to thank everyone for taking time out of your day to participate. And if you have any questions at all, again, please email us. You can email me directly at marla@ireda.org or at our info address at info@ireda.org. And with that, I will conclude the webinar. Thanks so much again, Jess and Cory. It was really great hearing your talk.
Thank you all so very much.
Yes,
Thank you.
likewise. Thank you all so much. It was a pleasure.
Have a great afternoon and happy holidays, everyone.